All right, so we're going to go with the prone lateral CT junction lateral brake technique. And so the patient is going to be positioned again on the stomach in the prone position. There's different techniques where people will, like, you can come up like overhead and like get in like this. There's also the one that I'm going to show here in a moment where it's going to be more of a lateral brake rather than a rotary movement. So a couple things. So this is a prime example where we need to accommodate to the patient's restrictions. So I'm going to just put that under there. And usually I'll put a pillow under their feet regardless, but definitely with the boot. All right. So then, Kobe, you're going to look to your other side there. All right. So this arm is going to go up at the head. Okay. So again, table height is going to be around the VMO of the leg. This arm, notice that as I pull down, right, I'm creating tension within his shirt. Thus, I'm also creating tension within his tissues as well. In a moment, I'm going to move to the other side. And my short lever applicator is going to be essentially, I'm going to come down, I'm going to grab his upper trap and use that, not his first rib. You won't thank you for that. And I'm going to grab this shoulder and bring it up. And then my thumb is going to be really the contact point. If this was a spinous process, I'm going to try and be like that. Okay. And then I'm going to try and gap it using my long lever applicator, and it's going to be like this. Okay. Again, the apex of my head and the rotation axis is here. If I'm behind it, then I'm going to create this rotational movement. It can certainly act like a zipper, and you'll get a lot of cervical. But it also creates a lot of traction, and you have some nerves and some vasculature that doesn't appreciate the traction, even though it may sound beneficial as far as like the additional cavitations you get up higher. This should be a relatively localized event. It's like 1.2 to maybe 2 cavitations, and it's almost always unilateral. It's like 80% of the time unilateral, and it's going to be on the opposite side of my short applicator. So in this case, it would, if my short applicator is coming here, then I'm going to try and gap the left side. And then if you want to just spin around to the other side as I apply it.
Oh.
Okay, the other thing I'm going to do is I'm just going to move the patient a little bit closer. And I use the pillow. You can use a series of towels, but essentially it's like this small contour, or I imagine it almost like a staircase or slant, in order to get the head to otherwise rotate appropriately. So by coming across like this, so I'm going to come up and over and try and get it right at that CT junction. Okay? And then you're going to essentially add a little bit of rocking to the point where their nose is going to be like this. It's going to be, if he's here, he's going to be rocking like this. And as soon as his nose faces the canvas, that's when I'm going to thrust, and it will be a combined motion. Again, the majority of it's going to be like 60-40, 60 coming upstairs, about 40% coming with my, that is the long applicator, and then 40% through the short applicator, okay? But there is going to be like this rolling and rocking maneuver to get him right into to loosen him up a little bit. If you feel him tighten up there, obviously you need to reposition and or make them feel a little bit more comfortable and loose before you actually thrust. So again, with this hand, I'm going to come in like this. And get it like that. Any questions?